With a focus on advancing emergency care, Zoll delivers innovative, user-friendly technology designed for where and how you work, and for the patients who rely on the care you provide. Zoll is committed to helping you save more lives.
Let me start off my talk by just sharing with you conflicts of interest in relation to this subject area, and they're academic conflicts of interest related to funding from the UK government and the National Institute for Health Research to evaluate the Lucas mechanical chest compression device. I have no commercial conflicts of interest to declare. Mechanical chest compression devices come in a variety of shapes and sizes, but they aim to perform a single function, and that's to deliver high-quality, consistent CPR. We know from the literature, and we've heard in the earlier talks today, the critical importance of achieving CPR of an adequate depth and maintaining that quality, of avoiding prolonged interruptions in chest compressions, and together, a mechanical chest compression device which can deliver consistent, high-quality CPR in animal models leads to physiologically superior resuscitation to attempts at performing manual chest compressions. So intuitively, a mechanical chest compression device, on the basis of the observational data that inform their design and use, they should improve outcomes, they should improve survival. But of course, in this type of situation, it's always important to evaluate how the technology actually works when you put it into the hands of EMS providers or doctors and nurses working in a hospital. And as I stand here today in 2016, we're now in the position, having had 4 high-quality randomized controlled trials, to have some really clear information about whether these devices are helpful or harmful if used routinely for the management of out-of-hospital cardiac arrest. And this slide just summarises the design and the characteristics of the 4 trials that have taken place across the UK, Europe and the United States. The Aspire trial was one of the forerunner trials that evaluated the Autopulse mechanical chest compression device, followed by the CIRC trial, the LINK trial and the Paramedic trial, which evaluated the Lucas mechanical chest compression device. And I'll just very briefly walk you through those studies and the salient findings from them. So the first of these studies was the Aspire trial conducted by Hallstrom and colleagues in the US and Canada, and the primary outcome of this study was 4-hour survival. The study, however, was terminated early by the Data Monitoring and Ethics Committee on the basis that survival to hospital discharge and neurological outcomes were worse in the group that had been assigned to mechanical chest compression. This led to a period of reflection and thinking about the optimal way, particularly to deploy a mechanical chest compression device in an EMS system, and led to the conduct of the CIRC trial, which was an efficacy trial designed in a CPR optimized system where the investigators spent a huge amount of time training the paramedics, introducing high-quality, quality assurance systems where they could monitor and observe the quality of resuscitation, as Professor Finn has just described, so that they really used the device in the most optimal setting. The primary outcome for this study was survival to hospital discharge, and as you can see from the odds ratio here, that there was no significant difference between the mechanical chest compression device and manual CPR. Moving on to the Lucas mechanical CPR trial from Sten Rubitson and colleagues in Sweden, and also some sites in other parts of Europe, evaluated the Lucas device, again in a slightly different approach, in that rather than simply comparing it to manual CPR, they investigated what they described as the Lucas system. So this comprised early deployment of the device, the delivery of blind shocks prior to the determination of the initial rhythm, and again trying to use the chest compression device early. Primary outcome was 4-hour survival, and as you can see really across the board of those outcomes there was no significant difference in any of the efficacy or effectiveness outcomes that this group studied. Our trial, the Paramedic trial, which was a pragmatic cluster randomised trial, apologies Professor Finn, which evaluated the Lucas mechanical chest compression device put into our health system in the way that the device would be placed into a health system in the NHS. So with some familiarisation of training for the paramedics that taught them how to use the device, but our NHS system doesn't have the high quality monitoring that exists in some other parts of the world. So once practitioners are trained in how to use the device is there for them to use, as opposed to there being any ongoing quality assurance programme. The primary outcome of our study was survival to 30 days, and as you can see on the odds ratio there, which crosses 1, there was no significant difference between the manual and the Lucas CPR arm. By contrast, the proportion of patients that were neurologically intact at the first point at which we measured neurologically intact survival was marginally lower in the group that had received mechanical chest compressions. We've synthesised these data in a systematic review and meta-analysis, and as you can see in the top of this slide, for survival either to discharge or 30 days, there was no significant difference in the combined results for the Lucas mechanical chest compression device, and similarly for the Autopulse device evaluated in the CIRC and the ASPIRE trial. We ran the same analysis for survival and neurological function, and again, if you note the bottom arrows shown there, or the bottom diagonals, each of those crosses the boundary of 1, so there was no significant difference found in terms of neurological outcomes compared to manual CPR with either the Lucas or the Autopulse device. Jas Saw and colleagues synthesised these data in part of the ILCOR, International Consensus on Science and Treatment Recommendations, and their synthesis of all the available data at the end of, or at the beginning of 2015, led them to conclude against the routine use of automated mechanical chest compression devices in place of standard manual CPR. They did shine a light, however, on the possibility that automated mechanical chest compression devices could still have a role in some specific situations, and particularly where it's difficult to undertake manual CPR. And I thought I'd focus the rest of the talk probably on that area around, I guess, where I consider that there's still a role for mechanical chest compression devices in out-of-hospital cardiac arrest. This is our European Resuscitation Council Advanced Life Support algorithm, and I thought I'd use it as the framework for considering the potential timing and basis upon which one could consider mechanical CPR. So starting on the left-hand side of our algorithm, which is the shockable side of the algorithm, I'll share with you the results from the 2 studies that included subgroup analyses for patients with an initially shockable rhythm. So you can see in the ASPIRE trial, patients that received mechanical chest compression that had an initially shockable rhythm, although not significant, the survival rate is about half that of those receiving manual CPR. By contrast, in a similar vein in our paramedic trial, we actually found a significant interaction amongst patients that were in initially shockable rhythms, demonstrating that survival was lower in patients that received mechanical chest compression devices as opposed to receiving manual CPR. And I think when we start to think about how that may have arisen, then we start to hypothesize, because neither of these studies had sufficient information to be able to unpick why there was a signal or why there was an effect that seemed to suggest that outcomes were worse in patients with initially shockable rhythms. And I guess I and others have hypothesized that this may be due to a delay in the delivery of the first shock because of the time it takes to deploy a mechanical chest compression device. It may relate to harmful interruptions in chest compressions during the process of deploying the mechanical chest compression device. Or some very interesting data, and apologising, the formatting seems to have moved slightly there, from the CIRC trial, Steinberg and Lars Wick, demonstrating that with the mechanical chest compression device, of course, you're able to deliver the shock during ongoing chest compressions. And Lars Wick and his group, and indeed on the right-hand side of the the slide, Robertson and colleagues looked at the effect with the Lucas mechanical chest compression device, and both seem to be pointing to an interaction between the phase of chest compression when the shock is delivered, with the Steinberg study demonstrating that if the shock was delivered during the compression phase, then the chances of it terminating fibrillation was significantly less than if it was given compared to the manual CPR groups. So a number of potential reasons which point me away from using a mechanical chest compression device, certainly early in the resuscitation of a patient with a shockable rhythm. And my advice in this situation would be to continue with manual high-quality CPR for your first loops of shock. And I guess by loops of shock, I'm meaning the first 3 or 4 shocks, so probably 10 plus minutes into your resuscitation attempt. There may be situations, and again, depending on local protocols and systems, and I think we are waiting for the results of high-quality trials to know if a patient remains in refractory ventricular fibrillation, if there's a role for taking such patients into a cardiac catheterization laboratory. In order to be able to undertake that research, which I think is an important part of the jigsaw that needs to be addressed, the concept of taking a patient in with ongoing CPR, it's clearly in many situations impractical to do that whilst undertaking manual CPR. Often the extrication from the location of the out-of-hospital cardiac arrest into the ambulance leads to harmful interruptions in CPR quality. And Richard Lyons from the Scottish group were able to demonstrate that with the use of a soft carry sheet, as shown there, that the interruptions in chest compressions were substantially less when they extricated patients from their home, from buildings, with a mechanical chest compression device, as opposed to trying to continue to do manual CPR on such patients. Of course, travelling in an ambulance is not without risk to the rescuer. And having an unrestrained person in the back of the ambulance obviously places substantial risk to that person and indeed anybody else around in the back of the cab. The advantage of a mechanical chest compression device is, of course, that you can sit down in a restrained position, thus reducing the chances that you as the rescuer will come to significant harm. There's also good evidence from Teresa Gavin and colleagues in Norway to demonstrate that during the actual transport of the patient into hospital, that a mechanical chest compression device is able to assure you of higher quality CPR than attempting to do manual CPR in the back of a moving ambulance. Mechanical CPR, as I'd started to allude to, can also, if one is going to take a patient to a cardiac catheterization lab, it becomes physically impossible to actually undertake manual CPR whilst doing a PCR, or at least it's at risk to the patient, at risk to the rescuer, and in many occasions practically impossible. And a mechanical chest compression device, it remains feasible that you can undertake percutaneous coronary intervention. And I think this is an area that we're waiting to get some results from high-quality randomized controlled trials before we're able to say whether this is something that should become routine or at least tailored practice. So that's, I guess, summarised my reflections on the use of mechanical CPR in the shockable side of the algorithm. In the non-shockable side of the algorithm, our guidelines identify that we should seek to treat reversible causes and that mechanical chest compression devices may have a utility, particularly where there's likely to be prolonged treatment or the require for transfer. And if we just consider a couple of situations, or at least we'll try and consider a couple of situations. I guess I've probably used my time up as the slides have